Good afternoon and welcome to the National Center for Rural Road Safety's Post-Crash Care webinar, Big League Safety Part 1. My name is Jamie Sullivan. I'm the director for the National Center for Rural Road Safety. We're going to go through just a few logistics for you about today's webinar. Today's webinar will be 2 hours in length. Note that that's a little bit longer than our typical webinar. To activate closed caption for the webinar, you're going to click on the Show Captions button at the bottom of your screen. You can also adjust the captions under caption settings with the same button, and you can see that icon on the top right of our slide right now. We are recording today's webinar for website archival. You can find that on our website at ruralsafetycenter.org/webinar-archive/. We do have a question and answer pod today to ask questions of our presenters and also alert organizers of any technical difficulties. Please go ahead and put questions in there at any time, and I will share those questions with our speakers when they are done presenting. We also likely will have a little bit of time at the very end of today's presentation to address additional questions. We will have handouts available for download. Those will be put periodically in the chat pod today. So that you can download those. There will be, we're hoping to be able to post both the PDF version as well as a link that you will be able to access it as well. We will ask if you could provide feedback at the end of the webinar via a feedback form. That just lets us know what additional topics you would like us to present in our webinars. And then we do offer certificates of completion, and an application for CEUs will be provided. You must apply for these CEUs via the link that you will get in your email within 4 weeks of receiving that email. Failure to apply within 4 weeks may result in CEUs being unavailable. I do also want to thank our co-sponsor for today's webinar, the National LTAP Safety Working Group. I also want to say happy Rural Road Safety Awareness Week to everyone. As you're working through Rural Road Safety Awareness Week this week, don't forget to use hashtag RRSAW2025 on your social media posts, and please tag the National Center for Rural Road Safety, whether you're doing things via Facebook, LinkedIn, or X. If you did do any proclamations for your state or your county, or any press releases, if you could share those with us at info@ruralsafetycenter.org, we would love to see those and also be able to market them for you as well. 2 other events that are going on this week for Rural Road Safety Awareness Week. The National Rural Transit Assistance Program will be holding a Facebook Live tomorrow at 2 p.m. Eastern Time for their Rural Transit Day, so please consider joining them. And then on Thursday, we will have part 2 of this webinar series that will happen at 1 p.m. Eastern. Again, that will be a 2-hour webinar, and we'll have someone from Kansas talking to us about their post-crash care liaison program. Someone from Maine will be speaking to us about countermeasures for post-crash care that they've put into place in their state. We'll have Responder Safety Learning Network talk to us about their resources and trainings that are available. And then someone from Wisconsin is going to talk to us a little bit about their crash reviews and how they conduct those and some of their lessons learned and countermeasures that they implement from there. I also wanted to make sure that everyone knows about the Road Safety Champion program. It's our Safety 101 program. We have 4 different pathways for this program. And I wanted to say congratulations to our 69 most recent graduates. They're now listed up on our website. We just released a blog post and an email congratulating all of those. The next round of modules is going to start on August 19th. Again, just a reminder, you can take these in any order. As long as you have completed them and received a certificate for the module, you're all set there. No need to retake a module. You can just fill in the ones that you haven't taken yet. Our core modules, there are 7 of those, will be available on Tuesdays from 2 to 4 p.m. Eastern Time in August and September. Then we will run our maintenance and construction pathway modules and planning and engineering pathway modules on Tuesdays from 2 to 4 p.m. Eastern Time, October, November, and December. And then brand new, we're going to be piloting our first responder and public health modules in those career pathways on Wednesdays from 2 to 4 p.m. Eastern Time, October, November, and December. There will be a slight change in time for 2 of the public health modules just due to trainer availability, so keep an eye on that. And then also please remember that a couple of these modules cross pathways. So if you're not seeing them in order when you go to register on our website, that may be the reason. For instance, first responder number 1 is also planning and engineering number 5. So it's being held at the end of the planning and engineering modules instead of at the beginning of the first responder modules. So just keep an eye on that. You can find out more information about the program at the QR code on the top, and you can find our registration at the QR code on the bottom. Those are both available on our website, ruralsafetycenter.org, under Road Safety Champion Program, which is under training. I'm very excited about the lineup for today. We have some great speakers to explain to everyone more about post-crash care. And I'm really excited to start with Crystal Shelnut. She serves as the Regional Trauma System Development Manager for the Georgia Trauma Commission, where she leads statewide efforts to strengthen trauma care in both pre-hospital and hospital settings. Her work focuses on improving outcomes for injured patients in rural communities through education, data-driven system improvements, and targeted initiatives such as Stop the Bleed and pre-hospital blood programs. Crystal has more than 20 years of experience as a paramedic and EMS educator and continues to practice in her rural Georgia community. Crystal holds a Master of Public Health from the University of Georgia and degrees in paramedicine and emergency management. And I'm really excited to turn over our webinar today to Crystal for her to kick us off and explain a little bit more about post-crash care. Crystal?
All right, good afternoon, everyone. Thanks for having me. And for the warm introduction, Jamie. So yeah, I work for the Georgia Trauma Commission. I've been in this role for a little over a year and a half. And prior to that, I served as one of the regional coordinators. So the Athens, Georgia area, I managed trauma programs kind of inside of our region, where we work to advocate between hospitals, pre-hospital medicine, and rehabilitation to really kind of encompass the continuum of care for our trauma patients here in Georgia. So I've got several topics that I wanted to cover, but first and foremost, I think, is the importance of rural EMS and the opportunity to advocate for our EMS services. Because you're on this webinar today, I'm sure that everyone fully recognizes the importance of our rural providers, but there was a couple of highlights that I really wanted to hit. So the picture, this is my most famous rescue in EMS. This was Delilah the dog, who was stuck in the mud in one of our very, very rural communities, and her owner was emotionally stuck with her. And I think that while it was kind of a funny day and an opportunity to serve our community in a different way, it really highlights and underscores the importance of your rural EMS providers. Often, your EMS agencies might be the only access to healthcare inside of some of our rural communities. You might not have a hospital, primary care physicians, or even an urgent care. And in those situations, your EMTs and your paramedics might be the only access to care. And I think that kind of outside of our traumatic injury patients, we know that there's a lot of issues facing our rural communities now, and lack of healthcare is certainly one of them. Related to our roadway safety, of course, we've got a disproportionate death burden on our rural roads. In reading over some of the material for the Rural Road Safety Week, y'all really did a great job highlighting why this is so important that we address the need with just exactly how disproportionate that burden is. And from your EMS providers, we also know that we've got a longer response time to get to some of these roadway incidents. And it's really important that once we do have our first medical contact, we have our EMS providers on scene. It's critical that we have appropriately staffed ambulances, that we have trained and equipped providers. And I'll talk a little bit about some of the programs in Georgia later on and how we attempt to ensure that those things are possible in our communities. So another kind of hot topic now in EMS is the need for EMS to be designated as an essential service. In many states across the country, EMS is not on the list. And the list that you see in front of you now, these are the essential services required in my state, in Georgia. And you'll notice EMS is not listed on them. We ensure that there are a lot of opportunities for access across the state from our government services. And it's something that I'll continue to advocate for, is the importance of making sure that we've got adequate access to EMS as well. When I first got involved with roadway safety and the safe systems approach, I was given the description of the Swiss cheese model, right? That we've got all of these kind of overlapping and intertwined systems where we ensure that we've got safer roads and safer speeds and vehicles and all of that. And that when we can overlay those layers, we ensure that fewer people fall through the cracks. And I love the concept of it. And the first time I heard it at a meeting, I said, "Oh, well, EMS is the charcuterie board, right? That when there are gaps in coverage for various public health initiatives, whether that be diabetes education or prevention, cardiac, and certainly trauma injury prevention initiatives, we see that EMS is ultimately the stopgap for all of those programs." And so I'm so appreciative to the National Center for Rural Road Safety for really focusing on the importance of post-crash care. Not having a robust system and not having an opportunity to mitigate some of the barriers that our patients face really kind of heightens that disparity between outcomes that we see in rural and urban communities. So the question I pose is EMS essential? And I think for anybody who's ever had to call an ambulance, not only would you agree that it is essential, but timely equipped providers is also essential to patient outcomes. So what do we do at the Georgia Trauma Commission? Our goal is to ensure that geography doesn't impact outcomes, right? That when we look across the state, we want rural communities in remote areas of our state to have equal access to trauma centers, ambulance services, and that we can ensure that we have similar outcomes related to timely surgical intervention and things like that. So we do that by supporting a number of different initiatives that I'll go over. First is we support trauma centers, and we'll discuss kind of a little bit on how we do that in a minute. We support the Georgia Quality Improvement Program, or GQIP. This is our data repository across the state of Georgia, where if you are participating trauma center, we're basically able to see information about our patients from ditch to discharge. So we can look at our data and see, okay, well, EMS had a 30-minute response time. We had a 30-minute extrication, and then it was an hour transport to get to a trauma center. We can look at what types of interventions were provided in the back of the ambulance as far as the emergency care. The same thing for the emergency department, surgical interventions, and on to rehab. So the idea is that every decision we make is data driven, right? We're able to really kind of get into the nitty gritty of what are the interventions that mean the most to our patients and to their outcome and survivability. So when the Trauma Commission started, this is what the coverage maps looked like for trauma centers in the state of Georgia. And if you're familiar with the state at all, you'll know that the white part at the bottom of the state, well, there's not a whole lot there. Those are all very, very rural communities, but have a large interstate, I-75, that runs through that portion of the state. And in the early 2000s, it was noted as the corridor of death because we had incredibly poor access to flight coverage from our air ambulance services and also our trauma centers. The picture on the right represents where we are now with coverage in the state when you have a state that chooses to invest heavily in ensuring adequate levels of trauma centers across the state. We know that we've still got areas to improve, but we're very proud of the amount of centers that we've been able to bring on board and how that translates to higher quality care across the state. So can building a post-crash care system and supporting your trauma system impact outcomes? And so this graphic represents where we started in the early 2000s, where the mortality rate was 16% above the national average in the state of Georgia. once we were able to invest in bringing more trauma centers on board, and we do that through supporting through American College of Surgeons verification. So we support the startup cost for that. We help provide their data repositories and start to support financially those trauma centers as we bring them into the network. So what we've seen is that as we can invest in that, as we can bring more people into the network, we're actually at 6% below the national average for mortality now across the state, something we're very, very proud of. If you'll notice, my graph ends in 2020. I think all of you will probably agree with me that data got a little weird in 2020. So we are continuing on that trend, but of course, there's a lot of variables that happened after the pandemic. So how do we get our money? This is one of the more unique programs that I know of to fund trauma systems, and we're able to use funds that are leveraged in super speeder fines. So in the state of Georgia, if you're caught speeding, you're going more than 75 miles per hour on a two-lane road or more than 85 on any other roadway, you receive an additional $200 ticket in addition to the local fine. Well, all of that money goes directly into the trauma network. So you'll see that over the last 10 years or so, we've really been able to generate significant revenue around the $2 million a month mark. And that's consistent. And all of this information can be found on our website as well. I'll give you the links to that on what the legislation looks like and how that's interpreted into our budget. But basically, we take that $2 million a month, or roughly $24 million a year, and it's divided into to two different buckets. We fund 80% goes to support the trauma system network. So our level 1 through 4, we fund a percentage of their readiness cost in addition to their data obligations for trauma registry. And the other 20% goes into our EMS programs. So what do we do for pre-hospital support? We've got a number of programs that really we've seen an impact across the state. So the first is an AVLS system, so the Advanced Vehicle Location System. This is a GPS and high-speed internet on all of our 911 ambulances across the state. So this allows your providers to have access to telemetry for accessing, various providers, whether it's cardiac, stroke, or trauma in other areas of the state, to send patient data like 12-lead EKGs and other important metrics to the hospital to do their patient care reporting. And then from the kind of emergency preparedness side, we can also access a database where we can see where all of those ambulances are. So if we've got a hurricane headed towards the coast, or we've got some other significant active threat type events, we can locate ambulances easily across the state and see what resources look like to help to mitigate that. So that's an important program. It's been going on for a little over 10 years now. With some really great support from partners at Georgia Tech and other agencies across the state. So the next is our ambulance equipment grants. And I think the next slide that I've got, yes, talks a little bit more about these programs. So in Georgia, if you are a zoned 911 provider, we provide a stipend for every frontline ambulance or every peak ambulance that works in your 911 zones. And the goal of this program is to ensure that we've got basic trauma care equipment that's provided on all of those ambulances. Everybody can talk about the kind of complications we face in funding EMS agencies. And it's our job at the Trauma Commission to ensure that we've got access to basic equipment. So needle decompression for chest trauma, tourniquets and wound packing materials, and even things to help to kind of improve the quality of care, like IV fluid warmers and things like that. We also include some training equipment that can be included and various types of extrication equipment. So those grants are annual. It's a really simple application. It typically doesn't take longer than 30 minutes to fill out the application, the number of ambulances, and the type of equipment that your service would benefit from and how that would impact your trauma patients. So we've got about 99% of our Georgia counties that participate in it. And by participating in that, we also, of course, have access to some data on what types of trauma patients they're seeing. And then we have them participate in our quarterly regional trauma committee meetings so that we're able to push out new initiatives and do some performance improvement and injury prevention initiatives with those agencies as well. So very successful program, something we're really proud of. And we hope that in the future, we're able to support our rural agencies even more by setting kind of a minimum funding amount. We know that a couple $1,000s when you run a 1 or a 2 ambulance service might not be that impactful when it comes to capital purchases, and we're hoping to set a floor so that there's a minimum amount of financial support for each one of those agencies. So the next program we do for our EMS services is education, and we spend about $2 million a year to support both initial education and continuing education initiatives across the state. So one of the programs that we're most proud of is the initial education. So our EMT and advanced EMT programs, the Trauma Commission funds between 40 and 50 of those programs annually. And what we know now is that this is just a vital tool for our rural communities to ensure that we've got a workforce. I know EMS workforce across the nation, we're seeing our numbers dwindling and our call volumes increasing. And this program has really served as a lifeline for our profession in Georgia. And we produce somewhere in the neighborhood of 700 newly credentialed EMS providers annually as a part of that. A grant from the Trauma Commission would include all textbooks. It includes instructor fees to help cover part of the cost of teaching the program, jump bags, so they get a kind of a starter bag of equipment, and then testing software. So one of the problems that we have with some of the programs is that we saw that we've got a higher attrition rate, and we're not necessarily where we'd like to be with success on the national boards yet. So we've instituted this testing program. So throughout an initial education program, the students are participating in these exams. We're able to data mine it on the back end and basically see how can we impact this student and their likelihood of success on the national registry early on in the program. And we've got some really great predictors on that now with about 92% accuracy. We know by the end of a program whether we need to remediate a student, bring them back in for some additional support, or if they're ready to go take their national boards yet. So very proud of that program. We also fund a number of continuing education initiatives. The picture that you see on the top left, that's from our Farm Medic course. Where this is a mobile program. It goes across the state, but of course focuses on the very wide variety of agricultural emergencies that we can see in our various communities. We farm a lot of different stuff in North Georgia versus South Georgia, and the program is really able to pivot to talk about what are the types of equipment that you might run into there, and what are the typical problems with it. We also do crash vehicle extrication courses, tactical medicine courses, and kind of a number of other programs. This is a picture that's taken from one of our trauma skills labs. So we're able to rotate this program. We do 10 of them across the state where our medics in rural communities and any community, but they're able to go in and practice those really low frequency but high acuity skills. Complicated intubations, managing complex chest traumas, wound packing and bleeding management. They're able to practice all of these on live tissues and really has served as an excellent opportunity to kind of knock the rust off of some of those skills that maybe we don't do as frequently, but they truly are life-saving interventions when we're presented with the opportunity to perform them. All right, and then the last program I wanted to discuss is the Georgia Trauma Commission initiatives around the bleeding control program, or the Stop the Bleed training. So in 2017, the Trauma Commission invested $1 million in this program with the idea that we wanted to place 12 bleeding control kits in every public school in the state. That comes along with training. So we've got to have at least 10 trained providers in the school system. And we've had 99% of Georgia schools that have completed that, which is just an amazing success. Well, the next wave was the commission said, okay, well, that fixes the in-school problem, but what about on our roadways? So the next wave of that was, can we train every school bus driver in the state of Georgia and provide them with a bleeding control kit available on their bus? And we're very proud that we now have 95% completion with that program. So in 2022, the commission went back to the drawing board and said, okay, well, what's the next area for impact? And it was categorized as government other. So law enforcement and fire departments, they've received training and have kits on their frontline apparatus. But this has also been extended to our road departments and county courthouses and rec departments. The goal is, and we're still fairly new in that program, but the goal is that if you have an incident on a Georgia roadway and you've got a school bus, a fire truck, or a police vehicle, you've got access to bleeding control equipment to include tourniquets, wound packing, pressure bandaging, and things like that. It's a phenomenal program for which we've had a lot of success. It's also opened the door for us to have other engagement on other injury prevention or performance improvement initiatives. So you can see what the kits look like, everything that's included in there. Each of our 10 regional coordinators has access to a great deal of training equipment. And then the picture on the right is that's me distributing about 1,200 kits down to South Georgia. We had kind of a backlog of applications down there, so I rented a van and loaded it up, and we headed down south. But a really great opportunity for us to advocate for all providers, whether they are lay responders or professional responders, to have access to bleeding control kits. And that's just a kind of a quick overview of the programs that we offer here in Georgia. This is my email address. If anybody has any questions or ever wants to reach out and discuss programs, we're an open book. Our website is very robust. You can find access to all the different programs and grants and the metrics on how we figured out what funding looks like. And I'm always more than happy to discuss what we do. And Jamie, I'm happy to take any questions if anybody has them.
Perfect. Thank you so much, Crystal. And thank you for explaining why EMS is so important, as well as all of the great stuff that you have going on in Georgia. For anyone that may have questions, please go ahead and put those in the Q&A pod, which is at the bottom of your screen. We'll give it just a second and see if any questions come in. Again, if you don't have any right now, but may have some later, we'll stop and ask some questions again at the very end of today as well. All right, so thank you, Crystal. It looks like we don't have any questions right now, but we'll circle back at the end if any do come in. Our next, I'm mistaken. We just had one come in, actually. A question for you, Crystal, is please expand on the key takeaways from delivering in person those bleed control.
So key takeaways from delivering them. I think that's our opportunity for more advocacy, really. So when we go into a school or we're going to our local law enforcement agencies, not only are we providing access to the training on how to save a life with a tourniquet or wound packing and the importance of that, but we really have the opportunity to expand upon many other topics as it relates to our trauma patients and to roadway safety. So that's kind of the importance of making sure that we get in front of the audience when we do these classes. But I think that the bleeding control information is really just kind of the tipping point for those programs and the support that we get.
Another question that came in for you was, did you get any pushback for the higher fees on speeding?
So it's not something that we've received is direct pushback from most communities around that. Again, it's something that's completely avoidable. It's not a tax that's levied across the board. It's not a fee that's levied across the board. But this really is, we want the super speeder laws to slow people down on the roadway. That is the primary objective, is that we slow people down. Outside of that, having some type of access to improving trauma care across the communities, that's widely supported. I think that when we look at what the data says about what are the primary causes of collisions, speed is consistently on that list. And if there's ever anything that we can do to slow our drivers down, that's the goal. And this is a way that we've experienced a great deal of success in Georgia.
Another question that came in was, how do people apply for the resources that you spoke about?
It's a great question. So for EMS, the equipment grants, those come out annually. So we keep a list of all of our EMS directors and they receive email notifications of when the grant period is open. As far as our communities, we open Stop the Bleed applications quarterly. So we send that information out to our RTAC coordinators, our EMS directors, and really anybody else's email address that I have. And they can go onto the Trauma Commission website. Again, it's a very quick application. I think it has 4 questions in it. And then your regional coordinator will reach out to you to ensure that you've had your training done and that you've got a plan for where you're going to keep your kits. And we usually have them ordered and distributed the following month.
Another question that came in for you was, do you have any follow-up or evaluation from the schools, buses, or others that you're providing the kits to, showing that they are using what you're providing?
We do. So all new kits that we order, inside the kit is the instruction manual, because that's important. But there's also a QR code. So if you use a kit in the field, we want you to scan that code. It's very, very basic information about what county were you in, what did you use out of your kit, and what was the day that it was used. Basically, we want to replace those kits. One, if we want to celebrate that we had a kit in the right place at the right time to save somebody's life, but we also want to replace it, and that's the way that we're kind of doing our data monitoring on that program. And oftentimes we're not able to get reports of things that happen inside the school. Sometimes for an extended period of time, if there's other components going on to it, whether it's an assault charge or something like that. But we have got a tremendous number of success stories from across the state on where we've had these kits at the right place at the right time, and we've trained people on how to use them, or to at least slow bleeding down until the kit becomes available. We've got a really great story of a high school senior who had just taken the training 2 weeks before. He and his buddies were involved in a roadway incident. He had to have a tourniquet applied to one of his arms. Unfortunately, he did lose the arm, but now is a phenomenal Stop the Bleed instructor across the state and continues to advocate for the program. So we do have a lot of success stories. We do highlight those quarterly at our Georgia Trauma Commission meetings. But of course, we'd always love everybody to tell us anytime they use them. But we are starting to get good reports coming in.
Another question is that you all have achieved major growth. What has been the limiting factor in establishing trauma care centers in rural areas, and how did you all manage to expand into those areas?
Yeah, so that's the most notable problem and a phenomenal question. So we've had some adjustments in our funding formulas on how we can bring rural trauma centers into the system. And one of those ways is the percentage of readiness cost. So that's how we fund our trauma centers. Is there was a formula devised on exactly what does it take to be ready to manage critical trauma patients at a level 1, 2, 3, or 4 center. And we're able to reimburse portions of that. Unfortunately, it's a lot lower for our level 1s and level 2s, but we reimburse nearly 50% of the readiness cost for our level 4 trauma centers. That's a huge financial obstacle for them to overcome, in ensuring that they have some of the systems and personnel in place. And then, of course, we do some of the data monitoring components for them as well. And part of our team will go out and help them do preparations for some of their site evaluations.
You've spoken a lot about the Stop the Bleed kits, and you gave percentages earlier about with the people that you're giving them to. But do you know
Yes.
roughly about how many are being used in rural Georgia?
So I know that we have deployed nearly 60,000 kits across the state, which is just an astronomical number. And again, I've only been in this role for about a year and a half. We started doing the the QR code and reporting your kit use about 6 months ago. And so far, we've had 34 reports in the last 6 months of the kits being successfully deployed across the state. And that's between schools, buses, and then our kind of government other category.
And we have two final questions for you, and then if any others come in, we'll hold until the end of the webinar.
Okay.
But the next one is, what techniques would you suggest to get other states to adopt the Stop the Bleed program?
I think that we were able to get initial support, unfortunately, because of acts of violence in the school system, right? And I think that having a plan on what are your top priorities for where these kits need to be, and then how you're going to plan on doing the training component. Honestly, the kit purchasing was the easy part. It's how to train everybody in mass. That really tends to be the obstacle. So I think when you can come up with a plan for that, the rest of it tends to fall in line. We were also able to this was not me. This was way before my time, but somebody had a great idea on if we're going to do a mass purchase from a company on these bleeding control kits. Well, can we negotiate that same rate for all Georgians? And the answer was yes. So now if this again, it's all listed on our website, but if a company, if an individual wants to purchase a kit and it's shipped to a Georgia address, they can also get the discounted rate for the same rate that the commission pays. And so I think kind of putting together, here are our primary issues and what we want to tackle. Is it violence in the schools? Is it, roadway injuries? Is it, what are you going to focus on? Kind of craft what that's going to look like, what's your training going to look like, and then ancillary programs that are going to support it, and then move that forward. But this is a scalable project. We didn't start with 60,000 kits in the field. We started with, okay, well, in a couple of schools, can we put these 12 kits in? Started slow, and as the ball started rolling, and we started to get some press on it, we certainly had a lot more people come on board after that because they wanted it for their schools as well.
And then the final question that we have for you right now is, does the state of Georgia have this post-crash care and these strategies that you've talked about within their highway safety plan? Are you aware of that?
We do. Yeah, we certainly do. I sit on a number of committees, and our governor's office of highway safety has such a robust team up there that yes, these programs are kind of integrated into the statewide plan.
Perfect. Thank you so much. That was a lot of questions that came in right there at the last second. So we appreciate the audience sending all those in. We're going to pause now and move on to our next speaker. But we will take more questions at the very end for Crystal. If you do have any more, please keep those coming in the Q&A pod. But now we are going to move on to Eric Lind. He's going to talk to us a little bit more about something Crystal already talked about, which was trauma centers and access to them. And Eric directs the Accessibility Observatory at the University of Minnesota's Center for Transportation Studies. He leads research and application activities, including the National Accessibility Evaluation Pooled Fund Study, to measure nationwide access to destinations across modes. He holds a PhD from the University of Maryland and has over 20 years experience examining complex systems through data visualizations and statistics. And we're excited to hand over the webinar to Eric.
Thank you, Jamie. All right. Yeah, thank you so much for including me in this webinar. This is really exciting for us. I, as was just mentioned, am not a doctor or a rural health researcher, but I'm a researcher of transportation. And what I'm going to try to do today is kind of work back to where Crystal started, as far as thinking about how to quantify, understand, and then ultimately improve rural access to trauma care with respect, especially to traumas from transportation itself. So where we start in our group at the University of Minnesota is thinking about transportation as a system of especially connections between origins and destinations. So I'm going to belabor that a little bit before we get started into the actual trauma center, trauma care destination. And what we usually say is we want to think about how to measure the performance of the transportation system. This is something that's being done all the time. And of course, in every state and local jurisdiction, the primary way that people measure transportation networks is by speed. Speed, or the converse, delay, the volume of vehicles, congestion, of course. And all these things are really very vehicle based. So part of that is because it's pretty easy to count vehicles through a number of methods and has been for a long time. Part of it is also just how people think about the transportation network itself. But the overriding metric that is used in this kind of performance evaluation is that fastest is best. So all other things considered, traveling faster along the network is a sign of high performance. Okay? Maybe not as fast as to be earning, the super speeder fines that we just heard about, but in general, traveling fast. We think about this a little differently when it comes to accessibility, and that's to think about things not from the network performance or vehicle performance standpoint, but from the people performance standpoint. And that's just asking the question a little differently. And the question we ask is, can people reach their destinations? And when you start to think about the origin and destination rather than just the movement along the roadway, you have some different perspectives on some of the same numbers. For instance, since we're talking to rural road safety, we know that all other things considered, that slower is safer. I mean, that's part of the message we just heard about the super speeders as well. Closer might be better, and being able to reach your destinations easily is really what we're trying to optimize. So easiest is best. If it's closer and you're going slower, that might be easier than a longer trip at a higher speed. So ultimately, this focus on ease, or the opposite, focus on cost, is what forms the basis for our domain of research, which is called accessibility. And I'll show this definition, which has been around for a long time. Accessibility as a word has a lot of different connotations in transportation and obviously medicine as well. But for our purposes, we think about access or accessibility as the ease with which a traveler could reach valued destinations. And the two parts that are important here in this definition are italicized. One is the ease. So that's mean you're measuring overcoming some kind of barrier, some cost to make it easier. The second one is could. So the reason that's important is because we're talking about potential travel, not observed, daily travel behavior. So accessibility is about opportunity. What could you reach? What might you want to travel to? And how easy is it for you to get there? And the reason why this is a different way of thinking about transportation performance is that it's a lot closer to what agencies can actually control. Like, they make possible certain connections or certain opportunities through the development of the transportation network and the different modes. They can't control necessarily the choices of people, but they can control what the opportunity landscape looks like. So typically when we're researching accessibility, we have a national project where we calculate, for instance, access to jobs. So for this map of Minneapolis-St. Paul region, which is where I'm talking to you from today, you can pick any point on this map and imagine if you had a car and you drove in all directions for 30 minutes, how many job opportunities could you reach in that time? So kind of think about your drive shed and what the opportunities would be. And this is a very common output of our work. We're sponsored by a dozen or more state DOTs to do these calculations for different modes across the country. But as Crystal mentioned, and I'll come back to in a second, economic opportunity is obviously one function of the transportation system, but there are many other types of essential destinations that people do need to reach in order to have, complete life, and that should be part of, what people are thinking about as we plan and measure transportation. So the way we measure this, again, we start thinking about origins and destinations, and then connections between the two using different modes. We think about this in terms of choices, and these choices apply especially in rural contexts. I would, maybe say even in rural contexts, but it's especially in rural contexts that we need to think about choices, because certainly there will always be a bias towards driving and private auto in rural contexts because of essentially the geography of the destinations. But cars aren't available to everybody. And I think we all know that even in rural areas, there are people who can't drive, can't afford to drive. It could be medical, it could be temporary, it could be age related, either too young or too old, and so on. So we always think about accessibility as this kind of comprehensive set of choices, but they're not always available to everybody. But the other thing we measure is costs. And there's always some kind of cost traveling from origin to destination. And for something like, walking or rolling to public transportation, that cost might be time. The $2 fare may not be the most important cost element, but the time it takes to wait, and in rural areas, maybe even schedule a transit trip could be the cost that people face. When it comes to cycling, people think often about the cost of safety and how they can navigate, shared space with cars or unshared space with cars in order to reach their destinations. As I mentioned, for autos, this could be monetary, certainly not cheap these days to own and operate a vehicle. And then as we also look at access in the pedestrian mode, and there are a lot of other complicated factors about the environment that people walk through that have a big influence on their ability to move between origins and destinations. Essentially, what we do is across the entire country, we take each census block as an origin, and we take as many different destination types as we can to put on the map, and we route trips between the two. So what that looks like is, for here in Minneapolis, you'll see a little black dot in the center of that map. That would be an origin. You'd start there and say you had a bike and you were going to take sort of safe and comfortable bikeways for 20 minutes in all directions. This is what that shape would look like. And what we do in our data process is to ask, well, what could this person reach? What can be reached in that travel time? Or conversely, how long would it take you to travel to different types of destinations? So that brings me back to, again, echoing Crystal's slide of the destinations that make up, an essential list. And we don't have anything official. I'm kind of curious to talk to Crystal maybe at the end about, how official that is or kind of where that gets enumerated. But for us, we're thinking about all types of different destinations that people need to sort of go about their daily life, but also that for the data process part, have representation across the country, are generally somewhat maintained and well documented, updated, and so on. So in our recent work, and we've been adding to this list, but you can see some of the echoes of that same essential destinations list in terms of jobs, education, of course, healthcare, groceries. We also have things like daycares and libraries and museums and things like that. And so what we're interested in is how does this play out in this case when it comes to trauma? And so the way we're coming to the questions that we've already been talking about today is from that transportation performance angle, but narrowing in on this one particular type of trip, which is emergency medicine and response to trauma centers. We were sponsored by our own center to look at this in the rural areas of Minnesota. And we actually were looking at a few of those essential destinations, including travel to high schools and travel to grocery stores in rural Minnesota under this umbrella of what's local. And we have a nifty little story map you can go through with the link at the bottom of the screen there. And you may have to type it in rather than click it. But it gives some examples of how our data are put together and what they can be used for. One of the things that we were interested in was exploring how access to destinations can help understand differences within rural areas, because we know that rural is not a monolith. It is not the same everywhere. And, when we look at our state in particular, there are certain geographic features that kind of define the ability to access things, the prairie versus the lakes or whatever it might be. But we wanted to kind of disentangle that and look at all the areas in our state and understand where access may be more or less limited. Just to set some context for you, the state of Minnesota 2020 population was about 5.7 million. We have one very large urban area and then a few smaller urban areas. So we kind of classify the locations of our state by their urbanicity or ruralness, if you want to put it that way. And within the areas that we classified as rural, you can see that while the majority of the population of the state is located in kind of that the counties around the major urban areas, there are still over 1 million people that live in the orange and red colored places on the map. So we're talking about a lot of people that are experiencing the types of access that we're trying to measure. Now, Minnesota, you may or may not know, has an incredibly robust roadway network throughout all of these areas. In fact, we are fourth in the state, fourth in the nation, sorry. It always surprises me to learn, but we have a lot of road miles running across the state. And for the purposes of thinking about trauma access, what we did, and also remembering that when we're calculating accessibility, we're not limited to trips that have happened, but we can think about trips that may happen. And so what we thought was considering all of these roadway segments and areas as potential crash locations. So Crystal mentioned analyzing crashes that had happened in terms of the travel time to the incident and then from the incident and all the different medical interventions that happened. What we're doing here is thinking about what about incidents that haven't happened yet, where those might happen, and then what the response times especially are going to be from those places. Now, in Minnesota, of course, like many other places, we have a goal of reaching 0 deaths. That's what TZD. And on the way to that, we have a goal for this year of 225 traffic fatalities. And at last count, we're at 176. So progress over last year, but still tremendously too many. And as I've been learning more about trauma and crash response in doing this work from the transportation side, it's my understanding that there is a very high percentage of victims of traffic crashes that are alive when they are reached even by EMS, but do not survive. And so the post-crash care, as we've been talking about, is extremely important. And part of that that we set out to tackle was the time element. How long will it take over-the-road EMS to get to and serve people that are injured? So this cartoon is kind of what we set out to do. Minnesota is divided into 90 or so EMS response areas. This map is a little crazy because it has the counties and the EMS response areas, but the point here is that those don't necessarily line up. They're not jurisdictional. They're based on obviously the healthcare network and other factors. So there's a lot of different areas of responsibility. And what we wanted to do was measure how long it would take an ambulance from its depot, from the response area, to potential crash locations. So in this case, what we're using is all of the mile markers essentially on the state highway network. And then from that location to the nearest trauma center. And here we started out using levels 1 and 2, and actually the data I'm going to show you today includes level 3 trauma centers that are reachable across the state. So this is sort of a two-step process. This is an example service area in sort of south central Minnesota. the town of Sleepy Eye, and the depot is kind of right in the middle of that service area. That's where the EMS personnel would load into the ambulance and drive out to the potential crash sites, which are denoted by those red dots along the highway network. And so they're responsible for all the red dots inside that black boundary. So we were able to route these ambulance trips, again, that haven't happened, but would happen in the event of crash in these areas. So we use data that we get from a big data provider to look at actual travel times. So this does include if there is any kind of congestion, which isn't always a big deal, but also the typical speeds on the different rural roads, which can vary a lot as well, based on their own, engineering and things like that. So we have really good travel time estimates for autos. And of course, we're assuming that the ambulances are not traveling that much differently than how traffic would generally move. And from what we understand, that is also generally the practice of EMS in our state. Okay, so the second step would be from that roadside crash incident to the nearest trauma center. We do have a lot of trauma centers in the state. This includes levels 1, 2, and 3. The levels 1 and 2 are not quite as numerous, obviously, where treatment can happen. But we included level 3 after some feedback from our partners that a common practice is to visit those in order to get patients stabilized before they're sent on. And what we're looking to do here is the travel time from those roadway mile markers to the nearest, either 1, 2, or 3. So that's what this looks like here. Oh, sorry, this is the first half of the trip as denoted by the cartoon there. So travel times from the ambulance depot to the roadside. And for most of the state, the geographic boundaries of those service areas make it so that most travel times are under 30 minutes. Some are as short as 10 minutes, sort of that lighter yellow area, which is generally pretty good. And we can come back and talk about the kind of step 0 of this travel time would be, well, are people, at the fire station waiting to jump in the ambulance, or do they have to be called from their volunteer stations to get there? So there's definitely some delay that might accrue beyond what we're measuring here. But in general, the ambulance system is set up so that most of the area can be covered pretty efficiently. But it gets a little trickier when we start talking about travel from the roadway to the nearest trauma center. And here we calculated travel times of up to 2 hours, so 120 minutes. And you can see in those darker red areas across the northern tier of the state, but again, also in kind of that southwestern area, western area of Minnesota, bordering South Dakota, there are places where within 2 hours from a roadside location, the ambulance will not be able to reach a level 1, 2, or 3 trauma center. So putting these together, we can make a map, which is essentially something like a risk map for trauma incidents on the roadside in Minnesota. And here's where you can see the darker colors are longer total travel times. Lighter colors are shorter travel times. But here's where we can come back to the idea that, not all rural is alike. There's a lot of variation in the different areas of the state. There are places where response times are pretty good. There are many places where they're well over an hour. And in some cases, we were not able to route the trip in under 3 hours total. So an hour from the ambulance depot to the roadside and 2 hours from there to the nearest trauma center. So this is a map that we've been working with researchers in our university and also with our state DOT, MnDOT, to think about how this could serve as a prioritization map for different types of interventions. Some of those might be transportation interventions. Some of those might be on the ambulance, like telehealth we were talking about. Some of them might be about locating facilities and expanding the locations where trauma centers can be. I also just took this map and put it into kind of a histogram shape where we're just counting the different service areas here. The red dash line vertical is at 60 minutes. Just thinking about that total response time of from the incident, uh, how long will it take the ambulance to travel from the depot to the roadside and from the roadside to the trauma center? So all those to the left of that red dash line are under that 60-minute threshold, but that leaves a lot of places in the state, and some significantly so, that are way longer than an hour. And so, again, not as an EMS or as a doc myself, I'm aware that this is a pretty critical, time threshold, and that, minutes obviously make a very big difference in these kinds of situations. And so this is just another indication that, this is not necessarily news to anybody in the state. I think what we're trying to add here is value in terms of quantifying how bad the potential problem might be and where that potential problem is worst. And I think those two pieces are what we're really trying to share with our partners right now. There are a lot of other dimensions to this. Of course, we do have air ambulance services. The trick with air transport, and again, this is not my area of expertise, but there are a lot of weather factors, and in Minnesota, winter being one of them. Many other times when it's very stormy, if you can't see, you can't fly type situation where over-the-road transport is still the primary method, even in some of the most rural areas. We've also talked about transportation, sort of travel time as a limiting factor, but hearing from some of the folks in our state too, sometimes those short travel times are not always accompanied by really highly skilled and experienced EMS personnel, and that the travel time might be sufficient, but the care on the way is obviously just as critically important. And I do think that we're expanding in our state the idea of doing more of the telemedicine on board, the ambulances, some of the things that Crystal was discussing. But yeah, just some other dimensions to think about. Obviously, we know that travel time is not the end all be all, but I think putting this map together helps at least focus some of these interventions, like where they should be prioritized, and where we might think about crashes as having different risks based on the post-crash care and travel times that are available. So I will stop there and say thank you for welcoming me into the Rural Road Safety Seminar, and I'm happy to answer any questions.
Perfect. Thank you so much, Eric, for going through all of that information. We do have several questions for you already, but just for the rest of you, if you have any questions, please put those in the Q&A pod at this time, and we will start addressing those. So our first question for you, Eric, is that I've heard the statement that a certain percentage of crash victims are alive when EMS arrive, but die before reaching a hospital. I've not been able to find this information for Arizona. Is there a national database that would help find that?
That is a good question that I cannot answer.
Perfect. And I also don't know if there's a national database. I don't know if Crystal or Dr. Rosenbaum know. I did put a link to the national stat that you were referring to in the Q&A pod. But Crystal or Dr. Rosenbaum, do you happen to know the answer to that question?
Hey, it's Crystal. I don't know that there's a national repository, but every state should have access to that through their EMS trip report.
Perfect. Thank you very much. Eric, another question that came in for you is, I guess this isn't actually a question. This might be an answer to the last question. It says, this is something we've been working on with several state colleagues. We think some of that figure is due to the access to care, but we also think a notable portion may be related to protocols. For example, death can only be declared by a clinician at a hospital, so the person is noted as alive at the scene, but are actually suffering from unsurvivable injuries or maybe unrecoverable. So that's just some additional information from one of our audience members as well.
Yeah, that's really appreciated. And obviously we should source this, and I don't even know if I said a percentage that I had in my head, but I think the main message of the post-crash care being able to save lives, I think still resonates. And so I think whatever that number is, I think it's going to be greater than zero, and it'll be important to think about how we can optimize that, especially given the importance of driving in rural areas.
Perfect. And thank you so much again, Eric, for presenting the data from your research. We really do appreciate that.
Of course.
Great. We're going to move on to our final speaker for today. We have Dr. Robert Rosenbaum. He is the State EMS Medical Director for Delaware. Prior to that, he worked as a clinical emergency physician for 26 years and served as a county EMS Medical Director for over 15 years before becoming State EMS Medical Director in 2021. His full-time role also includes medical direction for the Office of Preparedness, working on medical needs in disaster relief, sheltering, or public health emergencies. He has expanded the role of the EMS Medical Director in Delaware by developing innovative EMS projects, including buprenorphine administration by paramedics and whole blood for treatment for trauma patients in the field. Dr. Rosenbaum has also helped improve the EMS system as a whole, working with dispatch, first responders, BLS, ALS, inter-facility transport, and hospitals to make treatment effective and efficient with an overall aim of improving patient experiences and outcomes. And I'm very excited to turn over our presentation to Dr. Robert Rosenbaum, who's going to talk a little bit more about the whole blood program that Crystal also introduced us to during her presentation. So Dr. Rosenbaum?
Jamie, thanks very much. Hopefully you're seeing just my regular screen, not presenter view.
Correct.
All right, and it's a great chance to speak to you about a program we're very proud of in Delaware. Sorry for my clearing the throat there at the start of this. You see our nickname. We are the first state. We have a number of other nicknames. You may know us as the Diamond State. Apparently Thomas Jefferson referred to Delaware as a jewel. We are also known as the Small Wonder, the Blue Hen State. And for those of you who visit through and make big purchases, you'll be happy to know that we are the home of tax-free shopping. But we're trying to think from the medical side that we, really want to be proud of some of our innovations in being early adopters and actors in the field of advancing pre-hospital medicine with EMS, specifically now in advancing whole blood to be a statewide program and being the first state to place whole blood in every paramedic system. And I'll talk about how we've gotten here and the applications of whole blood in our system. We've successfully navigated to the point where we were able to put an implementation article out through the journal Transfusion. And happy to show this article. The DOI is at the top. It is accessible. The program here was innovative in the way that we're using multiple EMS systems and a regional blood bank. And this is important, I think, from a rural EMS standpoint, because of the difficulty sometimes in connecting with a local hospital. Some systems have chosen to use whole blood, where they actually take from the hospital and bring to the field. It's not really an option if you have a long distance to travel from hospital to event and back again. So you need to have a way to have blood within your EMS system. This article actually talks about a way to model that out for systems that might not be directly tied in with a level 1 trauma center, for example, but need to put whole blood into their pre-hospital care environment. We talk about in the presentation, rather, I'd like to walk you through some of how we developed this with some details and some of the specific areas to highlight in how we expanded, how we're monitoring this for quality, and what we've done within our protocols to build this into our EMS practice. We presented this through statewide implementation and to try to show the impact on our trauma care. We had to demonstrate that logistically we could make this work, that we could find a cost support to justify the use, the skill requirements that would be needed. This is within the paramedic scope of practice, but there are some specialized skills that needed to be developed in folks who hadn't done any transfusion or blood product administration in the pre-hospital environment. We piloted this program at our two busiest counties, and then brought the central county in Delaware on board after the pilot showed some success, making us again the first state to be able to do this on a statewide basis. This infographic was presented to our health and social service leadership and showed the impact of implementing this program in Delaware. And I highlight one piece of the slide that, 1 in 10 paramedic agencies, or less than 1 in 10, that is probably a gross over exaggeration. Talking to Blood Coalition, John Cromer in that coalition, the estimate is probably as low as 2 to 3% of paramedic agencies are carrying whole blood at the current time. So this is a real area where adding whole blood to the field can make a significant impact in post-crash care. And if it's something your system is considering, hopefully this will give you some starting points of places to look and ways to move forward. In our case, this was judged to be the most impactful project in the entire Division of Health and Social Services implementation in 2025. So again, I hope you're able to take some things from this and maybe build it into your system. So how did we get here? As I mentioned, this began with a concept really from our EMS providers several years ago, looking at THOR, the trauma hemostasis and oxygenation research, and programs specifically modeled after San Antonio's, but others who had been early implementers of whole blood. We took the impact, or the insights rather, from our EMS providers who had interest in doing this, and asked them to, kind of talk us through as stakeholders. What would they do? Where did they see this being used? What would they need to really model this out, and to work with them to design the concept. Once we had ideas on where we would use this, we needed to make projections on the impact of the service. So we've been using TXA, tranexamic acid, in patients with major hemorrhage, and that's dated back really over several years. We have a number of our EMS medical directors have some military medicine experience. TXA as a field treatment in military medicine has a long history. We built that into some of our pre-hospital care. Using that as a model, we looked at our patients who received TXA and said those patients would be candidates for pre-hospital transfusion. Our agencies then developed models using GPS and timing of arrivals of supervisors to identify if blood that would be deployed in the model we were considering would arrive on scene without delaying patient care. And we went back for a calendar year behind our implementation date to say, using this model, how many times would blood arrive? How many units would we use? And we further took that out, almost using game theory, to say, would we be able to do that within the 21-day shelf life of that unit of blood? And if a unit expired, we took it off the board. If the unit was utilized, we put a new unit into service. And we were able to identify that our utilization rate and our loss rate would be at acceptable levels for implementation. We advanced the concept through our Division of Public Health up to our higher Department of Health and Social Service, and had partnerships with Homeland Security, our State Emergency Management Agency, and our Board of Medical Licensure, who have oversight on paramedic scope of practice and standing orders. With their support, we moved this project forward. Our biggest barrier was obtaining blood. Our blood bank had never, or really our blood bank is the New York Blood Bank, which is a parent organization of many regional blood banks. They had not done this with any of their regional partners. We worked with them and had a number of very cooperative meetings between our EMS agencies, public health leadership, and blood bank leadership to design a concept that was agreeable and that was felt to be safe and effective with our blood bank partners. Cost factors were taken into consideration. Our emergency management agency was very helpful here, as were the individual EMS agencies in bearing some of the startup costs for equipment and for blood product itself. Concerns about waste, as I indicated, were addressed and were felt to be at a low enough level that we would not be taking blood out of the supply only to have it be wasted and not utilized. And we were able to demonstrate that the projections we had would have an impact with utilization rates being at a significant level that could result in better care, both for blunt trauma and penetrating trauma victims. So again, the barriers to overcome here, having a partner, knowing your utilization, getting support at your healthcare leadership. And really, I put this last event as this was sort of the tipping point for us. We were working on an active shooter training event, and our EMS Oversight Council is chaired by the Cabinet Secretary for Homeland Security, who also was attending this event. As good fate would have it, this was a profile about the Uvalde shooting, and our presenter indicated that San Antonio EMS had been active in taking several units of blood from their system via helicopter EMS, utilizing them during this event, and having successfully treated and then having patients survive to discharge with major severe shock index and hemorrhagic shock signs. The good faith here was that the Homeland Security had heard me talk about our model from San Antonio. What had not been moving forward quickly suddenly developed significant momentum, pushed in part by the Homeland Security Secretary at the cabinet level. So again, sometimes that overcoming of barriers is just good luck beyond good planning. We built a pilot protocol for treatment of hemodynamically compromising hemorrhagic shock. You'll note that one of our elements here was to not delay transport to initiate blood product. We did not, in some of our cases, our transport can be very short to our trauma center, particularly with its proximity to an area where we have a significant number of our penetrating trauma cases. We did not want to falsely create a model that said staying on scene to wait for blood is necessary or makes sense when we may only be a short distance away from our level 1 trauma center. The flip side to that is we have modified this practice to say that if you're in a more rural environment, if you're going to utilize helicopter EMS, it may make sense to allow arrival of a unit of blood. We have modified that further by adding our helicopter EMS systems into our agencies that carry whole blood. The criteria that are listed here for transfusion of blood products, this is not an all requirements to be met. These are any one of these indications can be an indication for transfusion. So it's important that if our providers have that high shock index and suspicion of hemorrhagic shock, that is sufficient to utilize treatment with transfusion of whole blood product. We do not need, again, to have all of these present. We also included our indications for traumatic brain injury. I did hear one of our questions came from Arizona. We modeled this off of the EPIC guidelines that have been championed out of the state of Arizona, that a patient with traumatic brain injury should not be allowed to become hypotensive, that the outcomes are significantly worsened, and that in systems that carry whole blood is the fluid replacement of choice for patients with traumatic brain injury and systolic blood pressure at or under 110. Our initial deployment of whole blood was in our, as I said, our northernmost and southernmost counties. The transportation corridors and the sort of gaps where we place supervisors in these counties is demonstrated by a north-south deployment in our northern Newcastle County and an east-west deployment in our southern Sussex County. Supervisors carried blood in the initial deployment model, and those supervisors were dispatched to high priority cases or cases where on arrival, either the BLS arriving first unit or the ALS arriving chase unit noted the patient might meet criteria for utilization of whole blood. So outcomes from our pilot phase looked at a number of metrics. The graph here depicts a utilization expectations. We expected that we would at a minimum use 10 units per month and at a maximum use 16 units per month. These were statewide projections, not based on just the 2 counties in question. You can see our utilization rate in red typically was within that window. The exception being January, really the December to February numbers. We have a significant seasonal variation in our southern county. It has a resort community. The population increases significantly in the spring through late fall months. So we do note, and you'll see in subsequent graphs, this seasonal variation continues. But we felt that the utilization being so high on the other months warranted an acceptable rate of utilization. We looked at measures of impact on survivability, and we looked at this both from a standpoint of the mechanism and indications for utilization of blood. This trial began specifically as a trauma indication for blood utilization. We did have several utilizations outside of what we would think of as typical traumatic mechanisms, with several postpartum hemorrhages, dialysis shunt bleeds, GI variceal bleeds, and in one case we had someone who was a victim of trauma who then had subsequent victim of penetrating trauma, rather, who then subsequently had a blunt traumatic mechanism with a motor vehicle crash. So we referred to that as a mixed mechanism. When we looked at our initial presentation, we were at about 57% of cases were blunt trauma, with 39% penetrating. Those numbers continued as we projected further forward and extended our data analysis into the spring of 2025, noting that we are still at about 54% blunt trauma, 37% penetrating, and now at about 9% of our administrations of whole blood for other causes. Again, with that same group of postpartum and dialysis shunt bleeding being high on the list of frequent utilizations of whole blood. Timeliness of blood administration was important to us, and we measured this by looking at the first ring of 911 to the time of the start of blood administration. And we did this for our first 12 or 14 months worth of cases. We specifically were able to measure this in Newcastle County, which is our more urban and suburban county in the state of Delaware. So again, the numbers may be less applicable in the rural EMS setting, but I'll show you a statewide as well. In Newcastle County, we were able to demonstrate that first ring to blood administration began in under 24 minutes. And on a statewide basis, so this includes our rural components as well as the resort community in Sussex County, our average was 29.2 minutes. I'll note that the data points that are outside of the upper control limit error bar at the top, there are 3 data points that exceed that. In all 3 of those cases, they involved a second unit being administered by a second arriving supervisor. So whether that was a second unit being given to an individual patient or a second patient who was entrapped on scene being given a second unit of arriving whole blood. But in cases of first unit administration by the first arriving supervisor, all of our administrations were within 50 minutes of first ring to 911, including our rural, suburban, urban, and resort community environments. This is another look at our Newcastle County administration with a histogram of administration of blood. You can see that some of our times were as short as 15 minutes for administration or under the 15-minute time block, with the typical at median being in the 26 to 30-minute block. And none of the administrations in Newcastle County exceeding 52 minutes from first ring to administration. When we looked at outcome, our first 100 patients, and we did look at Newcastle County specifically here, but the outcomes here in patients who were not in arrest prior to EMS arrival. 72 of the 76 patients we could get outcomes in that first 100 survived to discharge. You can see that 2 died in the OR, so they survived to hospital arrival, but did not survive further treatment. And 2 died after operative management, but did not survive to discharge. So based on these metrics, we felt that we had a successful pilot. The utilization rate was above expected. Our utilization applicability, which I did not mention, was over 98% within protocol. The utilizations in the pilot that were given for postpartum hemorrhage, for dialysis shunt use, for GI bleed, and for use in one patient where we felt that a tourniquet alone would have been sufficient. Those were felt to be outside of protocol, so 98% were given correctly within protocol. We had only 1 unit of blood in the entire 14-month pilot period that went out of temperature control, requiring disposal. We did not have any delays in care. We did not have prolonged scene times, and transfusions were averaging statewide within 30 minutes from first 911. I showed you the impact on outcome. And our expiration and waste, again, was felt to be minimal. We had, I don't know if I have that on the slide, our utilization rate and our loss rate was under 10% of units, which was felt to be at our target from implementation of the project. So we progressed to a statewide basis. This was put into our 2024 protocol update to go from pilot to paramedic standing order. It was implemented within our Central County in Delaware, Kent County, shortly after the protocols went live in November of 2024. Our Delaware State Police Aviation Unit, which is also a pre-hospital paramedic care provider. They were receiving new helicopters in the fall of 2025, which extended into December. And we didn't want them to be implementing a clinical project and an operational project at the same time. So they went live in February of 2025, at which point all state pre-hospital agencies in Delaware were carrying and utilizing blood. We additionally updated the protocols to administer blood to patients 5 and up. We had initially started this as an age 15 or greater. We added the medical indications that we had seen and the postpartum indications and obstetrics that we had seen for patients with hemorrhage from non-traumatic causes. And we had developed a plan to successfully recover and avoid the expiration of units of blood being placed in the field. So a partnership between the paramedic agencies, the Blood Bank of Delmarva, and Christiana Care as our largest hospital provider and level 1 trauma center allowed for return of whole blood units to the blood bank with a spinning down of that blood to extract packed red blood cells before they would expire. Christiana Care has a number of transfusion services where age of packed red cells is not felt to be a factor in their effectiveness. Whole blood, after it gets past a certain point, the trauma center did not want to use, for lack of a better word, aging out whole blood, but this was felt to be a way to salvage more than 60% of the product. We do lose the plasma, we lose some of the other factors that are involved, but it does maintain a utilization and an avoidance of a complete loss of blood product. Our new deployment model, if you recall from the initial slide, the north-south deployment in the northernmost county, there is now a deployment in the center of the county, which is where the airport is located for the State Police Aviation Unit. We add a central deployment in Kent County, which is near our state capital of Dover, and a southern deployment in our southernmost county, which is where the airport is located for our second State Police Aviation Unit. And here's an update of our whole blood utilization. Again, bar graph at the bottom shows you utilization by each agency. Newcastle County is our largest county and, not surprisingly, our most frequent utilizer of whole blood in the red bar. Sussex County typically runs as our second most active utilizer of blood. They were also at the pilot project, but they continue to utilize, particularly during these busy summer months. And then we have additional utilization by our State Police Aviation Unit and Kent County after they have come on board. The statistical change in our utilization rates and the median rate is shown in the green line, where we initially began at roughly 8 units per month. During the pilot phase, that increased to nearly 16 units per month. And with the addition of our 2 new units, we have already seen process change, and we are closer to 17.5 units per month at this time. Another way of showing you that monthly graph. We track and work with the Blood Bank of Delmarva to make sure that we are receiving valid data. We cross-reference with what we get out of our, we're an image trend state, so we extract data from that into a database. We cross-reference that to make sure that we're not missing anything. And the blood bank is also able to help us with tracking what we refer to as zero waste products. So identifying product that they have received back from individual agencies, and we track any expiration of blood. You'll notice that our Kent County, which is KEMS, and DSP agencies did continue to have some waste of blood early on. We do require that units have a 3 to 6 month validation period, that they are safely handling units of blood in the field without temperature variation. The blood bank does this before it will take units back. All of those agencies have now passed that probationary period, and we expect that from this point forward, we should no longer have any expired products and should be able to reclaim product on zero waste. Want to talk a little bit about data tracking if you're thinking about implementing this. We are working to create a statewide registry for our blood utilization and working with our EMS agencies to extract data to do so. We have the demographics and multiple pre and post data points that we utilize, and are working to extract as many of them from the EMS record so that there's no hand extraction or hand chart review. This will allow us to validate our decision-making, show the impact of our interventions, and hopefully work with our state trauma system of care to get outcome data, since most of these patients do arrive at our level 1 trauma center. We already have the cooperative agreement from that center to share outcome data with us. So we should be able to capture at minimum 90% of our patient outcomes. This database, I've snipped some of the tiles from the Excel spreadsheet that we have built this into. And we're still modifying a couple of these to make them almost exclusively extractable data points. But again, looking at things in the nature of the demographics, nature of the call itself, time of arrival, time of implementation, the mechanism that's led to the administration of blood, following protocol to make sure that we were giving TXA, calcium, crystalloid, etc. The shock index, both pre and post administration, where and how blood was given, any temperature dips for agencies that track that, and then some follow-up data on the bottom in purple, looking to see what additional treatments were given after hospital arrival. Was other blood or MTP activated for mass transfusion protocol? Did the patient survive? And was it to home, rehab, etc.? And if we can, we're trying to get the injury severity score, which, as I said, should be in at least 90% of cases, a capturable piece of data. We're also retrospectively looking to validate a tool that's been put into place called the Early Blood Transfusion Needs Score. Again, if you're a system that's considering whether blood is appropriate for your system, I would encourage you to take a look at this to demonstrate the need for blood utilization. This tool has been utilized by several agencies. It's been published and validated in a couple of journals, and has the opportunity for you to look back retrospectively to analyze, similar to what we did with our use of TXA. If that's not something you do in your system, this could be another way to justify blood transfusion needs. Looking at this scale, and if a patient has a score at 6 or greater, that patient is felt to have an indication for blood transfusion. I mentioned pediatric use, again, in post-crash care and in our patients in rural settings. These are not all going to be adults. We need to have the ability to utilize blood in the pediatric population. That has not been as widely studied. We had the benefit of military medicine with patients over the age of 18. Most of our trauma systems are saying that a 15-year-old should be treated like an adult. Some will go as low as 12. Reaching down to the age of 5 did take some cooperative agreement. There are some systems that will use blood at a lower age than this, but the evolution of pediatric use of pre-hospital blood continues to be a work in progress. At 5, we have not had any patients under the age of 9 given blood to this point, but we have had several patients under that initial age of 15. So our learning in future directions, we continue to focus on pediatrics. We've noted that the opportunity to treat patients with entrapment in a motor vehicle crash is one of our greatest points of impact for motor vehicle crashes, especially with adding the second units of blood arriving to scene. In our system, it's a tiered BLS ALS system, and our helicopter EMS is dispatched selectively for major trauma, whether by some specific mechanisms or by request of ground services. We have had a number of cases with MVCs with entrapment where our first arriving ground units administer blood and a second arriving helicopter EMS unit is able to administer their unit of blood either on scene or during transport. And in one case that I'll highlight, we had a high school student who was driving to school, who had a collision with a school bus, was pinned underneath the school bus, requiring almost 2 hours of extrication. That patient received 3 units of blood on scene and had a 4th unit ready to be administered, but became hemodynamically stable. She survived after 2 hours of entrapment, several episodes of significant elevations of her shock index, was discharged from the hospital and was able to participate in her graduation less than a month later. These are the types of calls where whole blood shows such a dramatic impact. And we are excited to look at some additional directions on dispatch code analysis, which is in progress for now over 200 calls with blood administration in Newcastle County. We're looking for patterns where a supervisor, if they were not already en route to the call, should be dispatched because of the high likelihood of blood utilization. And with that, I'm happy to take any questions. And I believe that the slide deck is available for sharing. So please, if you have questions after you review that, feel free to email me as well.
Perfect. Thank you so much, Dr. Rosenbaum. If anyone does have questions, please put those in the Q&A pod at this time. And that could be for any of our speakers, as we're going to be wrapping up here very shortly. So the first question that did come in for you, Dr. Rosenbaum, is for an agency or state that's listening today and hearing about pre-hospital whole blood transfusion programs for the first time, where would you recommend that they start as they maybe consider doing this program in their community?
Sure. So first off, I hope you are able to successfully navigate and consider it. I think whole blood is probably the greatest advancement in EMS care in the last 20 years. And I think it's the opportunity for us to provide the care that we need to blunt and penetrating trauma victims that doesn't just slow the clock, it may even turn the clock back and give them more time for survival. Some of the resources that I've put in this presentation, I would steer you to the paper that we've put in transfusion. It lays out what I've shown you here in pretty painstaking detail and was written by all of the contributors to this effort, from the paramedic agencies through public health, the Office of EMS. So it really gives you kind of a roadmap. Take a look at the resources and the sort of the patterns that I've talked about here with some of the identification of need. You want to make sure you're not going to put a lot of expense into something that you're not going to be able to implement, or you need to design a system that allows you to implement this in how you deploy your blood. And for every state, for every agency, that may be different.
Another question that we received for you is, if you were starting over, is there anything you'd do differently?
I do it sooner. I think that we recognized the things that we could show, but we had some of the barriers that we had in overcoming this valid concern that as a public health entity, we have to view blood as a precious commodity, and focusing on showing ways that would not be wasted, and showing that the positive impact would far outweigh the infrequent unit of blood that was not utilized. Once we devised a way to show that and demonstrate that, we were really able to move the process forward more quickly. That was probably our biggest barrier to overcome.
We had another question for you too. There was a chart that you showed, and the person is asking what accounted for the spike in units in December of 2024 for MCC. It seemed atypical.
Sure. So, couple of things can happen in December. So, if you've not been to Delaware, don't blink or you could miss it. But we do have a number of major highways that traverse Delaware. So one of the things that does tend to happen is we have a lot more holiday traffic, a lot more people passing through. So we did see some spikes in that amount. We also just with any month-to-month variability, it's not uncommon to have an unusual, month where you just have either a spike in violence or a spike in in either motorcycle or motor vehicle crashes.
And thank you, Dr. Rosenbaum, for again for the presentation and all of those answers to the questions. We do have one final question, but this one is actually for Crystal. So again, we're going to be wrapping up. If anyone has any last minute questions, please put those in the Q&A at this time. Otherwise, this will be our last question. So Crystal, someone is wondering if you also provide or encourage first aid training as well.
Hey, yeah, absolutely. The Stop the Bleed program, it really opens the door for us to have other programs related to trauma care. So it's definitely encouraged. It's not always something that we can provide, but we definitely connect to local resources who can. We're always happy to do the Stop the Bleed training, but that might only be, a 30-minute program where sometimes a formal first aid class is around the 4-hour mark. So, but of course, and that's the Stop the Bleed program really has been what opens the door for us to have a lot of better access to some of these agencies.
Right, and with that, I do want to thank one more time, Crystal, Eric, and Dr. Rosenbaum. Thank you guys for sharing your expertise. I hope that our audience today has learned a lot more about post-crash care than you knew coming in. And again, I hope you'll join us for the rest of this week for our social media campaigns for Rural Road Safety Awareness Week. If you're a part of our distribution list, you'll be getting a daily email which will explain the topic for that day, point you to our website for more resources, provide the baseball card that you see here on the screen right now for that particular day. We will be sharing all of that as well on social media, on X, Facebook, and LinkedIn. So please reshare those. Please go ahead and create your own posts as well based on this. Make sure you tag us if you do and use the hashtag RRSAW2025. Again, join us or join the National Rural Transit Assistance Program tomorrow at 2 p.m. Eastern for their Facebook Live for Rural Transit Day. You can go on and sign up for their event on their Facebook page right now. And then please join us on Thursday at 1 p.m. Eastern time for part 2 of this webinar series, where we'll explore a few more different strategies and countermeasures for post-crash care. So thank you all for joining. Happy Rural Road Safety Awareness Week. And thank you one more time to Crystal, Eric, and Dr. Rosenbaum. We really appreciate your time today.
Thank you. It was great.
Thank you for the opportunity.